Insert a femoral line. So first things first, whenever you're inserting a line and you're using sharp objects, you want to let the people around you know, whether it's in a trauma setting or a busy ICU. Hey guys, I'm about to use sharps, careful.
Thanks.
Okay, next thing you want to do is, if it's in the trauma setting, you're already wearing your own gown. If, kind of like a non-sterile protective gown, if it's in a sterile, safe environment, you want to then prep and drape and sterilize yourself. So first things first, prep. In the ICU where I have a little bit of time, I'll use some chlorhexidine, clean the patient off. In the ICU, in the trauma bay where I might not have time, just dump a whole bunch of betadine on it. Next step is prep yourself. So again, if you have time, put on sterile gowns, sterile gloves, full sterile technique. In the trauma bay, you might not have a whole lot of time, so at least get sterile gloves on. Then you would go ahead and drape your patient appropriately. Next things, since this area is now draped and sterile, I want to find out where exactly I'm going to be injecting and inserting the central line. Using my landmarks of the ACES and the pubic symphysis or tubercle, whichever one is easier to palpate. It's kind of here and here. And the nice thing is that if you make an L with your hand, the kind of crook of between your thumb and the rest of your palm pretty much tells you where you should be feeling a femoral pulse. So next I palpate, first with my hands horizontally, while my assistant here gives me a rapid heartbeat.
Nailing it.
So first horizontally to get a general idea, and then with my hand in a vertical orientation, using my fingertips to find out exactly where the impulse is the strongest. Since I feel it strongest right here, just medial to that should be where the femoral vein is, which is our target. So I make a little mark if I have a sterile marking pen or just with my nail, whatever. Inject a little bit of lidocaine, make a wheel just under the skin, numbing the entire area. While the lidocaine is going to work, I set up making sure I have all of my equipment. I'm going to need my large gauge introducer needle with a syringe. Additionally, I'm going to need my dilator. I'm going to need my guide wire. I'm going to need an 11 blade, little piece of tubing, finally my actual triple lumen catheter, which as the lidocaine is getting to work, I actually take each of the 3 ports, flush them with saline, taking note of where it comes out the end. Whichever port comes out from the tip is the one I leave open, the other 3 I clamp off. Okay, so now that the lidocaine has fully done its job, and we're confident that the patient is anesthetized, it's time to begin. So again, I find the point of maximal impulse, which I believe is right here. Then holding the needle like a pen with the open part of the bevel facing medially and the longer part facing laterally, angled towards the umbilicus. At a 45-degree angle, I insert while pulling back and see what I aspirate, which is venous blood right here. In real life, you wouldn't inject blood back into the patient, but this is a model and we need to conserve it. So I go ahead and do that. Next, I take my guide wire, and again with the little loop J thing at the end facing medially. I go ahead and introduce the guide wire. It should go relatively easily. If you're meeting a lot of resistance, then you're probably not in the right spot. So I've got confirmation from my partner on this model that I'm in the right spot. I go ahead and pull it off of the introducer. Next, having a firm grip on the actual wire, never letting go, I pull back on the needle. Remove it entirely and put it in my safety container. Next, I'm going to introduce the dilator. Again, never letting go of the needle. And you would, in a twisting motion, dilate down about 2 to 3 centimeters until you get through the fascia. Then you go ahead and remove the dilator. I take my triple lumen catheter and thread it over the guide wire. I'm looking for the end of the guide wire to come out of my open central port. As you can see, that hasn't happened and I've run out of wire. So what you can do in this point is to actually pull back on the wire and continue feeding until you see the end come out. You then go ahead and advance your triple lumen, advance it as far in as you feel necessary in the femoral artery. You're really not going to hit anything you're going to hurt, so you can you shouldn't hub it, but go 8 to 13 centimeters. At other parts, you might want to go less. I then finally use some suture to attach my triple lumen at a comfortable distance. I go ahead and check all 3 ports, make sure they're working, and then attach whatever I need to it. And that's it.